kind of a grand tour of the wonderful world of pediatric health economics. So some of you might think that, in fact, this is a fairly new phenomenon, that we haven't been really doing child health economics for very long, but you would be wrong. One of the earliest studies, in fact, in any kind of health economics was this study done by Michael Boyle and George Torrens and colleagues at McMaster in the early 1980s, where they looked at the cost effectiveness of neonatal intensive care for very low birth weight. So this was a classic cost utility analysis, and it was published as an article in the New England Journal of Medicine, and not just any article, it was a special article. And this was at a time, imagine 1983, some of you may actually not even have been born yet, when health economics was really at its fetal stage, really at the early stage. In fact, interestingly enough, in the paper, if you read the methods, they describe the use of utility instruments that sound suspiciously familiar, suspiciously like the HUI. And in fact, it was the HUI, and it was one of the first uses so early that it wasn't even called the HUI yet, but that's what they used. And so what did they find? They did this cost utility analysis, and they found that to apply to have neonatal intensive care services for very low birth weights, meaning newborns below 1,000 grams, cost $22,400 per quality gain, well below what we would consider an acceptable threshold today. So I thought it's interesting. Why even do this study? Why choose this intervention? And I mean, yes, of course, NICUs are expensive, but these are vulnerable neonates. What, are we not going to fund NICU services? So I think what's fascinating to me is that Boyle and his colleagues realized early on that it's not enough to make just a moral argument to finance healthcare services for children. We can't rely on altruism. One has to make an economic argument as well. You have to produce evidence. So what's happened since 1983? Well, to answer that question, welcome to the PED project. So this is something that THETA alluded to, and I'm glad to know there's someone else using it besides me, so thank you for that. And this is a pediatric economic database evaluation project. We have a repository of all published health economic evaluations, published in citation databases, but also published in the gray literature. We have over 75 HTA websites we peruse, and we include all full comparative economic evaluations where both costs and outcomes and a comparator are included. And we go back to 1980. So this is really useful. We look at each study, we look at the abstracts, we include them, and then we extract key characteristics about each of those studies. And you can search the database, and lately, in the last couple of years, in fact, we've added utility weights for all of the CUAs. So we describe the health state, we provide the actual utility weight that the authors provide, and the source of that utility weight, because the vast majority of time, in fact, it wasn't derived in that study, but it was referenced from another source. So what do we see in terms of trends over the last few years? Here's the growth spurt that I referred to in the title of my talk. It's really gone way up. These are the CUAs in blue, CEAs in blue, CUAs in yellow, and you can see tremendous growth beginning in the 1990s with the CEAs. CUAs start to catch up in the 2000s. And overall, we have just over 2,600 economic evaluations over this 34-year period, most of them obviously in the last 20 years or so. And in 2009 was a pivotal time, because that's the first time that CUAs exceeded CEAs as the most frequent kind of analytic technique in these studies. And on average, it has actually started to plateau. In the last few years, it's about averaging 120 to 130 studies per year. So what are all these people studying? We looked at the different intervention types. And here's an interesting point of difference between pediatrics and adult medicine. The largest proportion of studies were devoted to preventative interventions, immunization, vaccination, these types of programs, these types of interventions, not to treatment, not to pharmaceuticals. So there was about 900 studies here in the prevention category. Most of them, of course, CEAs, with quite a few CUAs. And here, health treatment, there were about 700 or so, I think, altogether, but 500 in the detection and screening. But I think it helps to put things in perspective. So we looked at the HTAs that were indexed in the Center for Reviews and Dissemination. This is at the University of York in the UK, International Database of all HTA reports. We looked at an almost 2-year period between 2011 and 2012. So we just counted the number of HTA reports for adults, children, or both in a number of different categories. So we have nearly 300 drug treatment economic evaluations in adults over this almost 2-year period compared to 25 in children alone. So you can still see the volume that we capture for children is still swamped by the activity in adults. But of course, there are many reasons for that, and many logical reasons for that. The incidence of disease is much less frequent in children, we know that. But even more than that, it's really hard to do prospective clinical evaluation studies in children. It's difficult to collect evidence. There's a lot of reasons for that. Historically, children have not been included in RCTs. And even though there are certainly incentives created to include children, things like patent extensions for pharmaceutical manufacturers, the reality is it's very hard to enroll children in randomized controlled trials, particularly double-blind ones. It's very difficult to enroll them. So what are the alternatives? Looking at population-based sources, well, at least in Ontario, there are significant gaps of evidence. There are no medications for case definition of a disease cohort. All of the subspecialists at Hospital for Sick Children are paid on salary, and the extent of shadow billing to OHIP is inconsistent. So there are complications with using population-based admin data for outcomes research. But one of the main reasons why we don't have a lot of evidence is just we have to wait so long to actually wait to see benefits accrue. Health improvements as a result of interventions, particularly preventative interventions, may not occur, in fact, for some time, for years, if not decades. So what are some of the other contextual issues we have to deal with? Well, of course, there are guidelines, great textbooks, most of them geared towards adults. And we're not talking about a single homogeneous population. There are children and adults. Children, of course, consist of many groups, from perinate or neonate to the adolescent, and you can imagine that each of these different age groups has a completely different set of important physiological characteristics that would influence response to treatment, maturity, development, and so on. So all of these things are critically important to understand when one tries to do research in this area. So the differences between children of different age groups as well as between children and adults must be recognized in terms of developmental vulnerability, dependency relationships, unique patterns of health resources, and unique patterns of morbidity and mortality. So why the heck do we do this? All I've given you is a laundry list of reasons why you don't want to do this kind of research. Well, why do we do it? So I think the pediatric health economist sees himself as this mountaineer dangling between the two mountains of health technology assessment and child health with a rope around their neck, hoping that they won't fall off. But so if you like mountaineering, this is the sport for you. All right, so now I'd like to go into some of the actual challenges of measurement and issues that we encounter and how we deal with them. And talk about costing, then I'm going to talk about outcomes, and then we'll talk about some specific studies as examples. So when we talk about costing, the first thing you have to realize is that often we have to go beyond the healthcare system. You can't take a strictly Ministry of Health payer perspective. Very often, in fact, the setting of care delivery is not in a hospital, it's not in a doctor's office. It's at home, it's at school, it's in the community. And costs are accrued to other individuals besides the child. The child's not the only consumer of resources, and they're also not the only one who accrues costs. So clearly, parents and other caregivers incur productivity costs in terms of absenteeism and presenteeism. Presenteeism is when, for example, parents continue to work, but at a much lower level of productivity because they are distracted by the fact that they have a sick child at home. So any kind of degradation or loss in productivity. But even more important, and this is very rarely captured, it's not absenteeism or presenteeism, it's change in work status. We did a study, a cost of illness study in children newly diagnosed with cancer, very deep interviews, qualitative interviews with parents, and we actually found that almost 50% of mothers literally quit their job when their child received the diagnosis. So these types of changes in work status also represent a production loss that are important to capture. Other aspects of productivity costs, of course, are those that are going to accrue to the child if they have a chronic illness that extends into the adult years. So they may have greater consumption of healthcare resources, reduced labor productivity, reduced participation in the workforce, and these are things to consider as well. Which means we want to try and build lifelong time horizons, if we can, costing by stage of development. Easy to say, difficult to do, because you can imagine if you were taking, for example, a Markov model, state transition model, you would need disease progression curves, survival curves that are unique to each of those stages of development. We don't really have that kind of data, so there's a lot of uncertainty associated with these types of lifetime models. So looking at the outcome side of the coin, just as I said, costing is not just about the Ministry of Health, so too outcomes. It's not just about health at all. In fact, a lot of you are parents that understand that child health is deeply interwoven with other determinants, social determinants of health and well-being, the physical environment, the social environment, biological and genetic determinants, behavioral responses. All of these interweave and make outcome measurement quite complex. And understanding what the heterogeneity in patients is also important to try and predict outcomes or differences between groups. Changes in all of these variables occur over the stages of physical development, and it becomes hard to measure. Hard certainly to measure directly from children, but also hard to measure from parents. Sometimes we have no choice but to rely on parents as proxy reporters of functional status along different clinical dimensions for children with different chronic illnesses or acute illnesses. And parents may not always be good reporters. They may be fairly good reporters for observable symptoms, let's say respiratory symptoms and so on. Not such good reporters for more subjective symptoms, so for example, pain, or even not such good reporters for children who are not at home, children who are now of school age, and who frequently are not at home and long enough for the parents to observe them. Certainly not good reporters for emotional states and elements like that. So we do use proxies, we use them all the time, but we have to be cognizant of the limitations. Don't get me started on trying to ascertain utilities. I could spend the entire hour just talking about challenges in measuring preferences for health states for children. So leave it to stay. It's challenging. We don't have really good instruments for children under the age of 8. So here's an example of a study we did a few years ago that kind of reflects some of these challenges and how we handle them. This was a study looking at the cost effectiveness of expanding intensive behavioral intervention for children with autism spectrum disorder. So these are kids with a neurocognitive condition, and they're treated through early intervention with behavioral therapy. The earlier the intervention is administered, the better the child will do. At the time that we did the study in the early 2000s, at that time, the Ontario Ministry of Health was only funding services for children who were diagnosed as being on the severe end of the autism spectrum. So we did an economic evaluation looking at the expansion of this program of services to all children, whether they were mild, moderate, or severe. At the time that we did the study, there was a lot of hot debate about autism services in the press. A lawsuit had been filed, a class action lawsuit by parents against the government asking for expansion of services. So we thought, okay, let's do a study and we'll submit it. And we wanted to see what evidence we have and what we can do. So we built a fairly simple model, but I'm just going to show you a little bit more about the study relevant to some of the points I made before. Is the intervention we're talking about for autism is purely behavioral. It's not medical. It's something that's administered by a therapist in a child's home or in other types of settings, but certainly not in a medical setting. The costs that we included in our study were those incurred by Ministries of Community and Social Services, Education, Child and Youth Services, and to only a very small extent the Ministry of Health. EIBI, or Early Intensive Behavioral Intervention, is currently funded by joint programs between Community and Social Services, Child and Youth Services. So there are pretty complex payer arrangements to provide care for these types of conditions for children. So health is a real small player in the costing perspective. And of course, costs don't only accrue as a result of child consumption of resources, for the reasons I mentioned before, also to parents. So outcomes. So we struggle with this quite a bit. We look at functional outcomes. There are a lot of different psychological battery of instruments that are administered to these kids to look at cognitive functions, social communication, behavioral adaptation, the Vineland score, intelligence. There's quite a few highly validated psychological instruments, all independent of each other, looking at very specifically, very focused way at different outcomes. We had no way to combine these, and we didn't want to choose one. And we were really interested in the burden on the payers. So what we did was we looked at dependency. We looked at level of dependency, meaning to what extent, when this child becomes an adult, can they live on their own? Can they live independently, free of any type of service or need? So that's the outcome we looked at. So I just want to show you now to begin with the cost. These are the annual costs, very simple lifetime delineation of cost from the provincial payer perspective, just to give you a sense. So these are the kids stratified by level of severity along the autism scale, the most severe, moderately, and the milder cases. And in the preschool years, ages 2 to 5, average annual costs were about $80,000 per year. This is cost to the ministry program providing the early intervention. And this is because of the therapy provided at home. Costs are very high, but only for an ideal situation for 3 years. Some of the kids actually don't even begin therapy. They're on the wait list, so they don't get it till starting age 4 or 5. In the school years, now the annual costs go down because it really only consists of special education services and some respite services for families. And respite is actually included here as well. In the adult years, which last many, many decades, the average annual costs go up quite a bit because now we're talking about day programs for adults with some type of disability, institutionalization, residential costs, social assistance program, employment services. These are quite a lot of programs are involved in providing care to adults with autism. And for the most severely affected, the annual costs could be quite high, particularly if they are having to be in some type of residential facility. And clearly the ones who are on the low end of the spectrum can function normally, so we attributed really no cost. So this is from a provincial payer perspective. In a pediatric health economic evaluation, it's really instructive to take a societal perspective. It's true there's no such thing as a true societal payer, and often we're doing these economic evaluations to service a particular payer question. But look what happens when we take a societal perspective and include the productivity losses of those children once they become adults. Looking at the adult years, particularly in the most severely affected, we go from average annual cost of $75,000 per year to just over $100,000 per year, considering that those individuals are unable to contribute to the workforce and unable really to be productive. And this is just assuming the ability to hold down a minimum wage job. So quite high average annual cost when it takes the societal perspective. So really you can understand that if you were to introduce an early intervention early in the life of that child and just shift this curve just a little bit to have a smaller proportion of the cases on the severe end of the autism spectrum and more cases on the moderate or low end of the spectrum, you can really incur a lot of savings. That was the idea behind us considering expansion of services. And that's exactly what we found. We found that the intervention was dominant with average incremental savings per child over their lifetime of $34,000 with an additional 2.8 years of dependency-free life years. So altogether, given the cohort of kids with autism in Ontario of about 1,000 children, that translated to overall savings of $45 million to the province. So our study was submitted to, this is during the trial, we submitted it to the court, which meant that and all of our details, all of our methods, everything in great detail was submitted to both sides of this court case, to the parents, lawyers, and to the government lawyers. And very soon after the case was resolved, actually the government won, which was interesting. The Ministry of Health won, the parents lost, and nevertheless, after we submitted our evidence, the Ministry of Children and Youth significantly increased funding to EIBI services to the preschoolers, but also to children over the age of 6 years. So there was a significant investment. I think it was a fairly easy argument to make, and it wasn't an overly complicated model that we used. These very conservative assumptions around effectiveness. And all the cost information was provided to us by the ministries themselves. They gave it to us. So I want to move from there to an area that really is starting to take over now, an area that we're doing a lot more work in, and poses, again, a kind of sort of head-scratching questions that are the most fun to contemplate. So this is the area of personalized medicine and child health. When I mean personalized medicine, I'm really talking about screening interventions, testing that is done specifically to diagnose disease early or to identify risk factors early that can be mediated in some way to avert risk downstream, to avert long-term poor outcomes in children. Often this is sort of the broad category of omics testing, proteomics, metabolomics, genomics. These are all types of different kinds of biomarkers that one can assay for, one can test for, that may provide some indication either of the presence of disease or the presence of some risk factor. This area is really exploding now. All these different types of tests are being determined. There's a lot of research, not just to develop the test, but to understand how diseases progress and to look for very, very early signs of disease, not only for treatment, but also to understand response. So some of this omics testing is useful because it provides a marker that you can use to track response to a drug or response to a treatment. So if we're looking at this type of testing, it's kind of screening or diagnostic testing, the kind of effectiveness variable that we're thinking about is one that is around the actual intervention, the technology itself. The effectiveness of the intervention can be expressed in terms of the performance of that intervention, the clinical validity of the test, the clinical utility of the test. So the clinical validity would be, for example, what's the sensitivity and specificity of the test? Clinical utility might be, what value does this test have to actual practitioners? Will they use it? Is it going to become part of routine practice? So thinking about that as the effectiveness measure, well, then we need to think about the costs associated with poor clinical validity and costs associated with poor clinical utility. So poor clinical validity, well, that means perhaps low sensitivity, more false negatives, low specificity, more false positives. These all have costs, and we need to consider them in our studies. Poor or uncertain clinical utility means that practitioners may not use it, may overuse it, may not use the test appropriately, and that might lead to overconsumption or overutilization of unnecessary health services. And the other aspect of this, I think, when thinking about this concept of personalized medicine, of course, is what about the patient? It shouldn't always be necessarily buried on the last row of the slide. What's the personal utility? What do patients think about this type of technology? So I'm just showing you this decision tree really for illustration purposes. It's a template of a tree that is actually used in more than one economic evaluation now. And it kind of suggests the way you might tease out the costs and outcomes associated with different aspects of this type of testing. So classically, the question might be whether you want to screen, in other words, first-line test people that you suspect of an illness, versus either waiting and watching, or if they already are diagnosed with an illness, to treat at full dose. So test first or treat first, and this would be followed by, test plus treat. So if you test, if you genotype, this deficiency that you're testing for is either present or absent. If it's present, the test is either going to be positive or negative. If the test is positive, that's your sensitivity, right? The probability of the test being positive if the deficiency is present. There's your sensitivity. However, in fact, some proportion of patients are going to test negative, even though the deficiency is present. Similarly, if the deficiency is absent, they're going to test positive or negative. If they test negative, that's a true negative, that's the specificity of the test. However, if they test positive, that would be a false positive. So you can imagine that, in the case of a true positive or true negative, you're laughing, everything is good. But here, if you miss the test result and the deficiency is present, and you're treating at full dose, for example, if you give a full dose of thiopurine to a patient with a deficiency in thiopurine methyltransferase, you're going to give them too much of a dose, cause myelosuppression, neutropenia, and even possibly death. So there's quite serious adverse events that could be associated with a test-negative situation. If they test positive, you have the opposite. Now you're reducing the dose or selecting a treatment based on a positive test result that isn't needed, and in fact, that patient may not receive the care or the treatment that they need. So my point being that each of these branches has costs and outcomes that have to be considered when you do an economic evaluation of any kind of screening or diagnostic test. You can't assume perfect sensitivity or specificity. Your model will be flawed if you do that. In this situation, this used to be the standard protocol for the Ontario COG, whatever, pediatric oncology group, but basically the situation was, let's get the child up to full dose. We know that thiopurine mutations are rare. If there's an adverse event, we're going to monitor them closely. Maybe at that point we'll test and then change the dose as needed. So that would be a more conservative approach. So what have we learned from doing some of these types of evaluations? Well, if it's about genotyping, well, then the first question, you kind of stand back and ask, well, so what if there's a positive test? It's not really the genotype that matters, it's the phenotype. Even if there's what that means is even if there's a positive test result, the patient may not express that gene in the same way that other patients might. They may not actually present with that deficiency. That gene may not have a high level of penetrance, or there may be other mitigating factors surrounding the genome. And this is, for example, the area of epigenetics is concerned with this. Other genes that modulate the behavior of genes that code for proteins. So it's important to understand not only the ideas around gene penetrance, but the heterogeneity in patients and why or why not that genotype or that gene may be expressed. This is the other lesson that we really learned from our TPMT economic evaluation, that even when you have a fantastic test, high clinical validity, 99% sensitivity, 99% specificity, you still may have a false positive rate that's greater than your true positive rate. So for TPMT, the mutation deficiency only occurs in 0.3% of the population. It's a very rare variant, but a very significant one because those children are at risk of a severe myelosuppression if they get the regular dose of drug. So if you have a rare mutation, this is almost always going to occur. The false positive rate will exceed the true positive rate, and so that you're going to be in this situation where these kids are either going to get the wrong drug or the wrong dose. So that's something to consider in terms of cost effectiveness. In terms of the clinical utility as well, I mean, part of your economic evaluation has to concern yourself with how the test is going to be used, and will it lead to more testing and further assessment down the road? What's the value of all of the sequence of testing versus the price that we have to pay to actually include it in our management plan? Also, this idea of willingness to know versus willingness to pay. Willingness to pay is one way to get at how individuals express their preferences for a new technology. But when it comes again to genotyping and these types of testing, we need to consider the disutility of the results. So there may actually be a downside to doing the test because of the information inherent in that test. If you're talking about the type of test that reveals variants of unknown clinical significance, or even ones that are of known clinical significance, but perhaps don't have an onset until the adult years, and it could be a very severe disease, do you really want to know that information? Or do the parents want to know it? Do they want to share it with the child? Do they want to ensure the child has it at age 18? There's a lot of issues around release of information and willingness to know the results of these types of tests. I think this is what Fiona referred to as epistemic injustice when she talked a few weeks ago. It's an important concept. The other issue, of course, the importance of time. The model I showed you just before was simply looking at the test and the test result itself. But when we're talking about selecting a treatment for a long-term disease, chronic condition, again, we want to model over a long enough time to look at that test-treat combination. And a long time horizon, of course, is going to be difficult to model unless we have those data. In pediatrics, children are living for potentially a very long lifespan. What does that mean for a long-term model? It means a lot of discounting. So when benefits are deferred for many decades, the discounted value of that benefit may be so low, especially in comparison to, let's say, upfront costs of starting a screening program, that it may in fact clash with societal values for what we want to invest in for child health. So the discount rate, we think of it, and many times, well, 3%, 4%, 5% will vary in sensitivity analysis. But if you're taking a lifetime time horizon over 65 years for children, it makes a huge difference, even 1%. Something to consider. All right, so now we're going to move to the next generation of testing, and it really is moving at warp speed. All right, so now we are actually in this world of next generation sequencing, which consists of whole exome sequencing and whole genome sequencing. Whole exome sequencing only looks at the components of the genome that codes for a functional protein. So it's a very small proportion of the genome, whereas whole genome sequencing is everything, pretty much everything from soup to nuts. The entire DNA code is sequenced. So I think rather than think of them as a technology, there's a lot of kind of aura around next generation sequencing. I think it's it's useful to take a step back and really place it on a continuum, looking at the evolution of this type of testing technology right from the beginning, where karyotyping, single gene tests to diagnose, to confirm a disease, panels, array hybridization, microarrays, whole exome, whole genome. It's all evolution of technology along a continuum. And at the same time that the technology is getting more complex and also more useful and producing a lot more data, our management practices are changing. And this is something that I think it helps to think about. We're moving away from single gene tests, confirmatory diagnosis, a very deterministic approach to disease management, to one that is almost entirely probabilistic. Because what are we getting from whole genome sequencing? We're getting big data, which is filtered through bioinformatics software, which will give the clinician a certain probability of the presence of disease and all kinds of ranges of probability of the presence of a variety of risk factors. So, and these risk factors may be for diseases that are downstream, long-term in the future. So what we're really talking about here is management of risk over the child's life, and at the same time, management of the knowledge of that risk. So this is where the world that we're living in right now, I think, with these types of technologies. Interestingly enough, with the study I'm going to show you, where we're actually looking at whole genome sequencing, they're still doing this for confirmatory testing. So something we're including in our costs. So it's ongoing now is a cost-effectiveness analysis of next-generation sequencing in autism spectrum disorder. The study hypothesis is that if we do this early, we have children undergo this test, it will give us a very early sign of the most likely presence of disease, get them in the queue now for treatment. So we're going to shorten that whole diagnostic odyssey. The children may still undergo all kinds of functional outcome testing, so they can be placed on the spectrum, but genomic testing can give us the early sign that it's present, allow them to get in the queue and hopefully get early intervention, because it's so critical to have that intervention early. The study objectives are to map out very carefully the pathways of care and changes in disease management practices that will occur with the introduction of next-generation sequencing, as well as to do the incremental cost effectiveness. And we're going to look at whole genome and whole exome in ASD compared to standard care, which is clinical microarray. So just a very general schematic of our model. This is all going to be using hypothetical patients. The model will be populated with data from 3 different patient trials, or 2 cohort studies in 1 trial. There's a number of different ways to screen, and in fact, this itself can be a separate research question around alternative screening modalities, diagnostic assessment, different types of genetic testing, and then the treatment. So if we blow up the green box, we're looking at genetic testing. So current standards, single gene testing, karyotyping, ordering the microarray, which is looking at the chromosome, gross abnormalities in the chromosome, versus the next generation sequencing, the whole genome and the whole exome. So what do you get? It's not simply now sensitivity and specificity, not just merely a positive and a negative finding. Typically, the results are categorized as variants of known significance, variants of unknown significance, and perhaps the absence of any variants. But even these secondary findings can be also categorized into ones that are actionable and ones that are not actionable, ones that are incidental, and ones that we want to come back to and study down the road in the future. And where you draw the bar is changing quite rapidly. It's a very, very interesting area of study. So this is what the model actually looks like in the background. This is a very complex discrete event simulation model that's been put together by Dr. Richard Zurich. And we chose to do discrete event simulation for, and I'm not going to go through it, but we chose to do discrete event simulations for a number of reasons. It's quite useful in this case. Certainly we're modeling costs and we're modeling outcomes, but a big part of this is modeling time. In other words, queuing for services. We understand that healthcare services are constrained. There's a fixed number of developmental pediatricians, a fixed number of medical geneticists, a fixed number of laboratories that can do the testing. So we have imposed constraints on the services that we need along this medical management pathway. So this is incredibly a useful technique when the new technology will create queues and impact access to care. Moreover, when there's a correlation between that waiting time to access treatment and outcome, this is a very useful approach to use. So we know there's a correlation. The longer the child has to wait for treatment to start, the worse their outcomes are going to be. So this is something that can allow us to see what factors can shorten or lengthen queue times given inputs around the resources that are available. So just to illustrate the model, Richard put together a really nice example of genomic testing prioritization. So normally, at the time of a microarray test is ordered, and microarray tests are not just ordered for kids with ASD, they're ordered for many, many different types of clinical conditions. All of these kids are put in a queue to meet with a medical geneticist to discuss the results, hopefully with their parents there as well. So the question was, what is the effect of a policy decision to allow patients with a positive microarray result indicative of ASD to move up in the queue to shorten their wait time for that consult with geneticists? All right, that's what we wanted to know. So basically, we're looking at a 5-year simulation model. So typically, in standard first-in, first-out queuing, you'd have all of these children. The ones with the red dots represent cases of ASD. And all we wanted to know was what happens when you prioritize and move all the ASD cases up to this 5-year simulation window. The inputs that we used for this example, the microarray diagnostic yield of 20%, wait time for genetic consult, this is actually what we've observed 6 months after test results. Genetic consultation capacity, we use 5 for the purpose of the example. Typically, it takes a great amount of time, counseling time, over 1 or more visits, 8 hours per case. And the number of children that would we be modeling over a 5-year period, just over 19,000. So priority queuing results, with this standard care, first in, first out queuing, about 19,000 kids are seen over this 5-year simulation period. But 4,300 of them would be with ASD, and the rest would be without. So children with ASD, assuming a perfect world in terms of screening and referral for genetic testing, for microarray testing, they would be seen at the age of 2.5 years, and children with other conditions on average just slightly older. If you prioritize the queue and you allow the kids with ASD to get in sooner, because early treatment really matters, those children with ASD then would be seen on average just slightly over age 2. Again, assuming a perfect world where they're screened and picked up right away and referred for testing right away. With only a slight increase in the average age of all of the other kids. So what does that mean for diagnosis then? We've really shortened the wait time for these kids. So in theory, although they may still wait for assessments, for functional outcome assessments, they can be put in the queue sooner now to receive treatment. And we're trying to, that's exactly what we're trying to do, is get them to be in treatment much sooner. All with the same number of genetic visits, same number of microarrays. However, of course, there's a consequence, and that's a delayed diagnosis for other children. And there may be other children in that group where time is also an element in terms of early treatment. So this is just an example of the kind of out-of-the-box analysis that you can do with a discrete event simulation model that's really relevant to healthcare planning and prioritization. So where are we today? We're still trying to figure out how to use this technology. Genomic testing is multi-purpose. It can be targeted, even whole genome sequencing. You don't have, even if you sequence the entire genome, you don't have to actually focus on all of the possible outcomes, all of the possible variants. It can be a very targeted use. But at the same time, we realize that much of the benefit of next generation sequencing is in its ability to provide all of these secondary findings that hopefully we can act upon, if not today, then very soon, to avert adverse outcomes. But if we wanted to try and do some kind of health technology assessment, we realize that we're now talking across different clinical subdisciplines, because this test is going to reveal results for all different types of conditions. All right, so as more is learned about the genomic base of disease, certainly the clinical utility of risk information will increase. So as we are doing these types of studies, the basic scientists are understanding the phenotype of these medically actionable variants, the secondary findings. They're understanding more and more about the phenotype every day, doing correlations between genotype and phenotype. But at what cost? Okay, so we're getting more information, more usable information out of this next generation sequencing, but what's going to happen? The diagnostic odyssey may in fact increase because these tests may lead to other tests, including, as I mentioned before, confirmatory testing. A lot of increased pressure on subspecialists, more appointments, more referrals to subspecialists when risk factors are found, increased costs to health insurance plans, more out-of-pocket costs to patients and families, and of course productivity costs. And what about the quality of life? So we're just beginning to really tap into some of the issues with this new scary world of next generation sequencing. How does it affect health technology assessment? Well, I think we have to take a different point of view with HTA. Now it's not just a matter of doing a cost effectiveness analysis as if that technology was static. We have to try to anticipate how that technology is going to evolve, because as I've shown you, this is a technology that is rapidly evolving, and we are seeing practice change, certainly with respect to how the test is applied, whether it's a targeted use, screening use, the setting of the test. In fact, it may be farmed outside of tertiary care hospitals to community-based laboratories. And in fact, the test itself is comprised of several tasks. There's the taking of the blood, which is different than the sequencing, different location for the actual bioinformatics piece, the filtering of the information, interpretation by yet another specialist, and then reporting of the results by medical geneticists to the family. Many different steps involved and different settings of these steps in next generation sequencing. So what happens if the setting changes? Of course, the payer may change. SickKids has brought us into the Genome Clinic project headed by Robin Hines to try and wrap our minds around trying to measure cost of translating this into a tertiary care hospital. But we're cognizant of the fact that the payer really depends on setting. So we need to understand the implications to payers if some of the aspects of this testing moves out to the community. Implications for HTA methods, again, looking at multiple clinical disciplines, looking at outcomes across different diseases, potentially lifetime models, a lot of complexity. And the other area I really haven't talked about at all that you can't get away from in HTA, and that's, of course, equity. So if you create a demand for tests and you create wait lists, particularly in certain locations that may or may not be underserviced, there are real equity implications with regards to is the test available and who has access to it? So we're seeing that, again, SickKids, sure, the families that come to SickKids, wonderful, they get this newfangled test, they may not want it. But so that's a very important concern, particularly for an expensive technology like next generation sequencing. And if only certain people benefit from the new technology, there are distributional effects in the population, right? So some people will show gains while other people will not. So this is my attempt to show how rapidly evolving this technology was. Only a short while ago that the whole genome was sequenced in its entirety. Can you imagine 10 miles of track laid in one day? And now we're over here, I'd say the train is still a few generations away from where it will be in a few years, but it is really a rapidly evolving technology. So this thing kind of helps, more press coverage, right? So here's a headline from a couple of years ago, I think now. Why cheaper genetic testing could cost us a fortune. And it's not a coincidence that you see a child in the picture. So already, certainly the media and many communities, many people in society are starting to twig into the fact that there are ethical concerns, there are issues, there are costs. This is something I may not want the information, I may not want the answer. At the same time that we do HTA, we must explore the social values around next generation sequencing. And to a greater extent, not just next generation sequencing, but technology in medicine in general. This idea of innovation and the speed of innovation creates mistrust. And it's not a coincidence that we see headlines flashed about the anti-vaxxers, because I think that a lot of people they miss the point. It's not about evidence, it's not about intelligence. The families who decline to have their children vaccinated are not stupid. It's a question of values, it's a question of trust. And I think that we need to kind of reframe the argument and understand the impact of technology on our society. So to conclude, I hope I haven't scared you away from pediatric health economics. It should be policy relevant, of course. You want to see it actually be used, and it should be responding to the real needs of healthcare providers making decisions for individual patients. At the same time, it is a cool area to work in because of all of the gaps in the methodology. Trying to develop outcome measures, trying to model over the long term, integrating family preferences, and especially with next generation sequencing, thinking of a more holistic approach to HTA that crosses multiple disciplines. So I'm going to just end by giving a big thank you to members of my team, Richard Zor, Lila Roy, who can come today. Heather Burnett was a big member of my team for many years. All of my students, some of you guys are here, and my colleagues as well, and several funding sources. So thank you all very much, and go here for more information. Questions? You look like you want to ask a question. So I think the first thing you have to do is be cognizant of the gaps. So there's no medication claims unless you go into, let's say, the Trillium database. But it, unless your question is geared towards really vulnerable children in a welfare population, and they move in and out of that program, it's not that useful. So if medication claims, for autism isn't treated with medications. There may be diseases where it doesn't matter for the purpose of your case definition. I've tried for a couple of times to get an audit of the amount of shadow billing of subspecialists to OHIP, and I haven't been able to get a good answer. But my sense is that some clinical subspecialties have a very high percent of shadow billing. Shadow billing is, even though the physicians are paid on salary, they still submit a claim to OHIP as if they were in a fee-for-service arrangement so that it will be in the OHIP database. And to some specialties do a good job, so I think it's very question-specific, so I wouldn't rule it out entirely. I will say the way I've used the population data sets is in this way. Enroll a large cohort of kids prospectively. I have a cohort of almost 1,000 children with asthma enrolled at sick kids in various clinics in the community and get their consent to link their data to OHIP records and then follow them prospectively. That's a useful way, because then you've got this cohort and you can follow them over the long term. It's more work intensive. So I'd say it's very question specific. And although I sort of, there are not a lot of RCTs, there are a lot of observational cohort studies. And for the discrete event model, we have 2 very large cohort studies with real patient-level data, with very good outcomes data, and mediocre health services data that we're going to use. And we have a very good prospective controlled study with excellent resource use data because we designed the resource use questionnaire. So we're triangulating 3 different sources of data for our discrete event model. And there are fantastic cohort studies in IBD, one of my students is working on, in other areas as well in pediatrics. So with like propensity matching, create control groups. You don't have the RCTs, you have to be a little bit more imaginative to have control comparisons. Yeah.
Very nice. Like the probability using the formulas you already have.
Yes, you could do that. So if you have a residing cohort, so the 3 cohorts we have with autism are, 2 of them are enrolled right across Canada. So some small proportion of them will be in Ontario. So we don't have admin claims as part of that study because we're doing a lot of follow-up. We're doing very detailed follow-up on this cohort. So yeah, you can probably do a deterministic linkage if you have their consent. You just need to get the consent.
Regarding the enlightenment, it's also emerging for adults, not just for children. So regarding economics, are there any lessons that adults can implement?
I'm sure there are. That's where we usually start, is with adult methodology and see if you can apply it or not. I'm just speaking in general terms, right? All of our health economic methods have been implicitly developed for adult studies. So we apply them, and only when we encounter problems like trying to measure utilities, then we say, well, we need to do something different. One thing we do, and we did this, I did a study of the use of biologics in juvenile idiopathic arthritis, and this is, again, a chronic debilitating condition. There were actually pediatric RCTs, but they only went as long as the follow-up period, so maybe 2 years of data. So we took all of our estimates and we went to a panel of pediatric rheumatologists, and then we pulled all the adult data and we said, is it reasonable to assume that the adult estimates can predict future outcomes for kids? So in fact, they felt comfortable with it, and we used adult estimates in our model as well. But you need some pretty rigorous criteria for using adult data. You have to be fairly comfortable with the ability to generalize from adults to kids. You can't always do it. But I think it's good to try. I wouldn't rule it out right from the starting point. Yeah.
How do we estimate the disabilities of knowing or not knowing? And they would be different, I'm assuming, for parents and children.
It's a fantastic area of research, all this preference ascertainment. It's hard to do any kind of preference studies with children. We've tried to do some with adolescents with mixed success. I think the questions around this utility, around information, would have to be the subject of the research question with an appropriate preference method used, like a discrete choice. I'll tell you what's interesting. I read this in a paper by Julie Ratcliffe from the UK, who did best-worst scaling with adolescents to time-derived utilities. And she did a comparison of best-worst to standard gamble. I don't know if time trade-off was in there or not. In the standard gamble, when these adolescents got the standard gamble, regardless of the variation in the probability of death, even when it was really high, the kids all chose the gamble because they thought it was like a game, right? Oh, gamble. So, you know, I mean, it's just sort of an extreme example of being careful with techniques like standard gamble when you have a pediatric response population.
Unfortunately, we're over it.
Okay.
So thank you very, very much, Wendy, for very inspirational. I think a lot of that I think about.